The cure for type 1 diabetes is right around the corner. Thank you for joining us live on our TCOYD live today. So we are going to go through the 5 kind of like hottest topics, hottest areas in type 1 diabetes research that are, get these, we're going to list them and then go through them in kind of a lot more detail. So we're going to talk about cellular therapies, which is kind of like islet cell transplants, new immunotherapies to delay the onset of type 1 or to kind of halt the progress once it's started. New technology updates, of course. There's a lot going on in that area. Something that I'm very passionate about, non-insulin therapies for people with type 1. Can we use Ozempic, Mounjaro, those kinds of things? And finally ending with gene therapies for diabetes, which is something that people might not have heard about. So,
not Jordache, but it's very exciting, and Jeremy is an expert in that area.
Sometimes buying some new genes can just help out as well. Anyways. So tell the folks who you are, Steve.
Yeah. I'm Dr. Steve Edelman, and you are Jeremy Pettus. Mm-hmm. And I should just tell you all that we just got back from this huge technology meeting in Amsterdam. And the main reason to tell you that, we both got the same cold. Mm-hmm. We may have to cough here and there, but we are totally knowledgeable about these topics to the latest month in terms of advancement. So we're excited to tell you about them.
Yeah. And on whatever platform you're watching, please enter questions that you might have. So we're going to kind of talk for 20 minutes or so, and then we'll get through as many questions as possible. So whatever platform you have, that'll get kind of funneled to my computer, and I can answer those. So, these are in no particular order of importance, certainly. But let's just start with kind of these cell therapies or islet cell transplants. So do you want to kind of tell people
Sure.
what this is, a little background?
Well, you know what? I am super excited because for the first time since I was diagnosed a long time ago, when someone says, do you think there's going to be a cure for type 1? I'm not going to say 10 to 15 years. I'm going to say a couple years. Because Vertex, sort of the leader in the field, they are synthesizing islet or beta cells. Then they infuse them into the portal vein. That's a vein that goes into your liver where they live. They use the blood supply, and these are fully functional beta islet cells. They secrete insulin, glucagon. They auto-regulate the glucose levels. And in the number of people they have put it in so far, they are off of insulin. Blood sugar is completely normal. And there's one caveat you need to know, because this is new therapy, and you have to take low-dose cell rejection therapy or low-dose immunosuppressants, and I underscore low-dose. The FDA said, well, for the first group of people that we'll give you approval for, they have to have some other condition that improves the risk-benefit ratio. And that's people with type 1 with severe hypoglycemia. Mm-hmm. And so that's sort of do you have anything to add to that?
Well, I think, it's worth highlighting, like you said, so when you were diagnosed, what year were you diagnosed? 70? I'm not trying to call you out here.
Yeah, no, 1970.
1970. And how long were you told there'd be a cure?
For so long.
Yeah, but it would be 10 to 15 years.
Every
right?
time. I mean, 10 to 15 years. And to have the thought that I could go to an infusion center, they can synthesize, as you always say, they can make beta cells for everybody on this earth now. Mm-hmm. You don't have to go to cadavers. And to have that infusion into the vein, into the hepatic vein, which is easy, and to have them live and make you free of injections, of the highs, the lows, etc.
So this is still in the research, arena. It's still, pre-approval. So this isn't approved yet. You can enroll in one of these studies. Yeah. The company's called Vertex. That's, kind of leading the charge here. So you can go to their website and see where they're conducting the studies. But the idea is that once that it's approved, that people could be potentially eligible for this if they have issues with severe hypoglycemia. And generally people, when they get these infusions, yes, they're able to come off insulin or drastically reduce the amount of insulin they have. Their blood sugars improve dramatically. They essentially eliminate hypoglycemia. So I always say that there's been several barriers to doing this in everybody with type 1. The first one was the source of the cells, that up until recently we had to rely on cadavers, that people that were in car accidents and they were organ donors that would donate their pancreas, and those would be harvested for transplant. Now we can use stem cells to make as many cells as we need for everybody in the world with diabetes. And that's the beauty of stem cells, that these cells are actually kept alive in the lab in perpetuity So it's also important to say that these aren't coming from embryos or things like that. This is that kind of the ethical issues around this have really been kind of put to bed. So we have enough cells. The final kind of barrier is that you do have to take this low grade immunosuppression so you don't reject the cells that are given to you. And right now, when this is approved, you will need these immunosuppressive drugs, likely lifelong. But the next phases in research are, can we change these cells in some way? Can we modify them so they're kind of, the immune system doesn't see them? Or can we encapsulate them in some kind of device? So that'll be the next kind of hurdle in research. But man, what a big, major development that we're as close as we are.
Yeah, and Vertex is doing studies in all those areas. I love this phrase, the CRISPR technology. I thought it was something to make your apples like really crunch when you bite into them. But it's really meant to change the beta cell just enough so that the immune system doesn't recognize them as foreign.
Yeah.
And that would be ideal. And then, of course, Dr. Pettus here has been working on encapsulated islet cells. God, how long now? Over 10 years.
Well, we did the first trial of this with a company called ViaCyte in 2014, where we encapsulated these islets in these little devices and then implanted them under people's skin. And it had issues with the immune system would actually kind of attack the device itself. So that there's a lot of work now in how do we modify these devices so that we can keep these cells alive, because islet cells don't need to be in the pancreas.
Right.
They just need to be anywhere that they can sense the blood for what the glucose is and respond with insulin. So we can encapsulate them in a device and kind of put them anywhere in the body, which is very different than a liver or a heart transplant that has to go somewhere very specific.
And Vertex is working on that as well. And these little encapsulated devices, they prevent the immune attack, but they allow blood supply in so that these cells survive.
Yeah. So the good stuff can get in and out, glucose and insulin, but the bad stuff, the cells can't attack them. So
cool.
It sounds like science fiction, but it's happening. So that is a huge area. I mean, we could talk about that like all day long. And we've done a lot of videos on this and actually some podcasts that you should listen to. There's one with Marcy.
Yep.
Oh, yeah, and Aaron Kowalski from formerly JDRF, now Breakthrough T1D, talking about all these advancements.
We did a podcast with Aaron, and he said to me, I expect to have this therapy available before the end of this decade.
Yeah.
So that's less than 5 years away.
Yeah, and then Steve and I will be cutting hair or whatever, other job.
Starbucks.
I could be a bartender.
I want to be a
maybe.
barista. Yeah, you would drink all the profits.
A beerista. That's what I want. I'll be a beerista. You be a barista. All right, so that's cell therapies. So the next one that's kind of in the same vein is what we're going to call immunotherapies. Okay, so we just talked about giving people islet cells back, like Steve and I that have had diabetes for a zillion years. What about, preventing type 1 diabetes in the first place, or once you get it, helping preserve the insulin-producing cells that are there? So we have talked about this therapy called Tzield extensively. It's approved now to delay the onset in type 1 diabetes in people that have these autoantibodies that are found in their blood, and it's been shown to delay the onset of type 1 diabetes by 2 to 3 years. So again, we've talked a lot about we need to screen people to find people that are at risk of getting type 1. And we did a little video on how to actually go about that. Anybody can go to this website, screenfortype1.com. It gives you different options on how you can order these kits. So it's not for people that have type 1. It's primarily now for first-degree relatives. If you want to test your kids, your brother, your mother-in-law, if you like her, as you always say, family members that you like, you can go onto this website. They can actually send you a kit at home. And you can do a finger prick and find out if you're at risk for type 1, and you might be eligible for this therapy.
Yeah, and let me add that you can get type 1 diabetes at any age.
Yeah.
And it's not just a childhood disease. I think like 60% of patients are over the age of 20 when they come down with type 1 diabetes. So
I was just going to say, it's a big reason why JDRF changed their name. I mean, JDRF, Juvenile Diabetes Research Foundation, they realize it's not just a juvenile disease anymore, sorry.
No.
Yeah.
That's good. Well, you know what? It was a painstaking move for them, but I think it was a good move. Yeah. Everyone's getting used to breakthrough T1D. So I think that some countries like Italy, they are screening every newborn or young kid for type 1. And they're way advanced because you can get type 1 at any age, as I said. But the low-hanging fruit right now are first and second degree relatives and those with other autoimmune conditions. So you have things like celiac, hyperthyroidism called Graves, and hypothyroidism called Hashimoto's. And they have a much higher rate of coming down with type 1. So I think it's, it's interesting. If you're all type 1 out there, we're not talking that you should be screened, obviously, but, your loved ones should be screened. And think about this. Let's say your son, who's 8 or 9 now. I mean, to delay it in your son for 3 years while other advances are coming down the pike, I think it's invaluable. And then plus, they've shown that in people who screen for these studies, if they eventually do come down with type 1, it's not a crash and burn.
Yeah, because you're educated, like, you're aware. So when you and I both got it when we were 15, it came out of nowhere, we were healthy.
ICU.
Yeah. Gosh, wouldn't it have been nice to know that your antibodies are positive, you're at risk, we could have avoided DKA and all that.
You sort of learn the eating stuff. You got your CGM right there.
Yeah.
You learn about it, and you're not so freaked out.
So I would say the big development at, kind of at this conference, but just in general around Tzield, is expanding the indication. So we just said that it's approved to delay the onset of type 1. There was a recent publication where they gave it to people who were just diagnosed with type 1. So they just came down with DKA, high blood sugars, they needed insulin. But when people are diagnosed with type 1, they still have 10 to 20% of their beta cells that are left. And those can kind of come back online and start producing insulin. That's why people go through this honeymoon period a lot of the time, where diabetes isn't so tough because your body is still making insulin. And so the idea is, can we essentially preserve that honeymoon period as long as possible? So in this study, they took newly diagnosed type 1s, gave them Tzield at diagnosis, and again at 6 months later, versus placebo, and found that ultimately it did help preserve insulin production and did have some meaningful kind of clinical benefits, including increase in time and range and A1C and things like that.
Yeah, I think that'll be huge. Preserving, we always talk about preservation of the beta cells. And like you said, when you're first diagnosed, you still have beta cells that work. And this honeymoon period, all honeymoon periods come to an end in real life and during with the beta cells. Because these honeymoon periods, the person might think that they're cured.
Right.
But it always comes back to requiring insulin therapy. So that's, we just hope the FDA approves the data and gives the indication for that.
So to be specific, again, it's approved right now for delay in people that have these autoantibodies to delay the onset. We're hoping it'll be approved for new onset type 1 diabetes, but it's not there yet. But if that happens, we think this drug will get used a lot more because it's very easy to find newly diagnosed type 1s. You don't need to screen them. They come to medical attention.
They're looking for us when they get diagnosed.
Exactly.
Yeah, just say real quickly, the therapy, is this Tzield, the anti-CD3 monoclonal antibody. Jeremy loves when I say that. For the stage 2, pre-type 1, it's 30 minutes a day for 12, 14 days,
14
right?
days,
Yeah. And then if it gets approved for brand new onset type 1, it's going to be 14-day infusion.
At diagnosis and then 6 months later.
It's only 30-minute infusion, so you don't sit there for 14 days.
Yeah.
So it's relatively easy, well tolerated. We had a patient that we managed together recently, and she is
And we did
doing
another
awesome.
podcast. We actually interviewed her and talked to her about her whole process of what it was like, getting the antibody screens and doing the infusion and all that. So check that out. I think that was maybe our most recent podcast, or maybe one behind. But all right, so next category, and it's a big one, is technology. And this has really been kind of leading the charge in terms of advancements in type 1 diabetes, really in the last decade. I mean, gosh, how far have we come? I mean, 10 years ago, we didn't really have any AID systems, automated insulin delivery systems, and now we have 5, right?
5.
So like the choices are becoming more. These systems all really help in terms of improving blood sugar, et cetera. I would say a big movement in this field that came out at this conference also is that we're moving away from having to choose like a system. So, it used to be if you're on the Tandem, you had to be on the Dexcom. Well, now we're moving towards being able to pick the pump and the algorithm you want and the CGM that you want and kind of, combine them in a way that you want. I mean, that's ultimately what we should be able to choose, right?
Yeah. These 5 systems, how do you pick one? There's different things you should look at, like you always help differentiate by, is there tubing? And if there's not tubing, the size of the reservoir. And they all have their ability to communicate with the CGM, give you insulin automatically when you need it, turn it off when you don't. And this algorithm, we always talk about the algorithm, it's very secret. Every company has their own algorithm. And I'm a firm believer that anybody can do well on any of the 5 systems because it takes input by the person living with diabetes. You don't just slap it on and forget it.
Right.
But they are different. I always encourage people, in fact, we have a program coming out on it soon. Speed dating with hybrid closed loop systems. So we should just go through them. The 780G, which took over for the 670G, thank God.
And that one's one to pause on real quick. So that's the Medtronic system.
Yeah.
And forever, you had to be on a Medtronic sensor. So this year,
Yeah.
they're actually going to team up with Abbott and the Libre, so you could use a Libre sensor with the Medtronic pump. So I think that's just a really good example of kind of what I was talking about, that we're going to be able to mix and match these things.
No, that's a great point.
Yeah.
And they also have their new flat, better form factor, Simplera, coming out as well too. And it depends on which country you live in, depending on the availability. And then we have the Control IQ, and now we have the Control IQ Plus and the Mobi.
Mobi's the smaller version of the tandem pump that we've had forever that you can wear on your body. So kind of like an Omnipod type approach for tandem.
Yeah, and then we have the Omnipod 5. And the Omnipod 5 is now, as you know, it's a patch pump. And it's approved officially for type 2. So is the Control IQ Plus. But all these systems, they are promoting to people with type 2, and it worked quite well in those groups. Then we got the islet. That's the one that's quite unique because the user just has to put in their weight to start off, takes a couple weeks to get to know you, and you make a meal announcement. Not like, hey, I'm going to pig out. You're going to a small, medium, and large meal. And these.
So you don't enter carbs, you don't have to enter a correction factor or a basal rate. It just starts kind of giving you insulin. And when you eat, you're supposed to tell it at least that you're eating. And you say, I'm eating a typical amount for this time of day, slightly more, slightly less. So it's very kind of hands-off and very kind of, I guess, big picture rather than I'm eating 32.7 grams of carbs or whatever.
Yeah. I have an older woman with on multiple daily injections for many years. She just didn't want to deal with the pump settings, and we have her on an islet. She's doing extremely well. And then the last one, the twist.
Yeah.
Tell them about the twist.
Well, it's not out yet, but this is a new pump that should be out any day now, but right?
I think it was out last month.
Oh, okay.
Should have been.
Okay.
No, it's not out yet.
So it's another tubed pump, but the kind of novel thing here is that it uses the algorithm has been used in this thing called Loop for a long time. Loop is a non-FDA algorithm essentially that people have been using, like Steve, for a long time to kind of hack their system and use this really sophisticated algorithm. Anyways, that's now going to be used with the Twist pump, and it is a really good algorithm. It has lots of things that you can toggle, and you can get really kind of precise with your blood sugar control. And so it'll be available now in an FDA-approved format, so you don't have to download it, some weird app and do all the complicated computer stuff.
It's not that complicated.
Yeah, but it's a thing.
It's FDA approved, and they'll have trainers and a place to call, so it's much better support.
Yeah.
It's very small and holds 300 units. So, depending on your daily use, you don't want to be changing your pump out more frequently than every 3 days. And so you want to go with a pump that has enough reservoir. But I'll just say one more thing about this meeting we came back from. In terms of these hybrid closed loop systems, all the companies are showing how well they work in different populations. So they have pregnant women. They've done a study in pregnant women, how it deals with the menstrual cycle, and that's always a hassle for a lot of our patients going through menstrual cycles, young kids, and almost every situation you can think of, hybrid closed loop systems show, better A1C, more time in range, less time below range, and then these PROs, patient reported outcomes. Everybody's super happy with them. So, we used to give lectures on, pump versus MDI. It's a choice. And now we say, no frickin' way. You better pick one of these systems. It always does much better.
Yeah. All right. So again, we've done a lot of updates on technology. We did a podcast with David On recently and go through these more in detail. So,
You want to mention just briefly about bihormonal options coming down the
yeah, I
pipe?
think the idea there is that there's always been this idea of, can we add glucagon as well? So insulin to bring your blood sugars down, glucagon to bring your blood sugars up. There's actually several companies working on this now. And the hope there is with both hormones, you can start to really get a fully closed loop system, meaning that the user doesn't have to do anything. And that is the next hurdle. And just like we're talking about the cure being in the next handful of years, it's going to be in the next couple of years, 2 or 3, that we have these kind of more kind of set it and forget it type technology than we do now.
Yeah, the algorithms will get better.
Yeah.
And these companies, they all have good products, but they're competitive. So that'll help drive innovation. There may be a time in the near future where we don't even have to announce anything.
Yeah.
Like you say, hey, I just ate.
All right. So last couple categories, I want to make sure we have time for questions. So category 4. So we've done cell therapies / islet cell transplants, immunotherapies, technology. This next one is these non-insulin therapies. And again, we've talked about this a lot. I would say the class that we're most excited about in type 1 diabetes is these GLP1 drugs like Ozempic, like Mounjaro. And here's the bottom line. These drugs work in type 1 diabetes. There's no doubt about it. We know that. We actually use them in a number of our patients, but they're not approved because the companies haven't done the official studies. So what that means is when a drug is not approved is that Steve and I can prescribe them for our patients all day long, but they might not be covered. So that's been a major barrier to a lot of type 1s using them, is they can't get the insurance coverage. So these drugs help with blood sugars. They help people lose weight. We think that they'll help protect people's hearts and kidneys like they've been shown to do in people with type 2 and obesity. And the major update here is that several companies now are pursuing the indication in type 1 diabetes. So Eli Lilly, that makes Mounjaro, is starting large phase 3 studies in type 1 diabetes to get the actual approval so type 1s can get this prescribed, and some other companies that aren't really on the radar right now as well.
Yeah, I was just thinking while you were speaking, what would you prescribe it for other than weight loss? And you mentioned it. There are other benefits that are most likely very similar in type 1 as they are in type 2. Now, we should say that if you have type 1 and your BMI, which is a calculation based on your weight and your height, if it's over 27, then you are eligible to get, Ozempic and Mounjaro, but the forms where they treat obesity. So that would be Wegovy and Zepbound. Same exact compound.
So it's a little bit of a loophole that you would be treating it, using it for obesity, which then might help get it approved. And then recently, Mounjaro has just been approved as a therapy for sleep apnea. So that might be another venue. What we do when we see patients with type 1 diabetes, or what I do, is there's diagnosis codes for everything. And there is a specific code called type 1.5 diabetes treated as type 2, which basically means you have type 1, but you have some features of type 2 diabetes where you might have some high insulin requirements or weight issues.
Yeah.
And a lot of times that can be a way to get these drugs approved. So it is doable. Don't let your providers say that these are a complete no for you, because generally we can get people on these.
And I have a bunch of patients on them, and type 1s, and they do extremely well.
Mm-hmm. Yeah.
You may not need the highest dose. I don't know, in my anecdotal experience, the type 1s need a little bit lower dose than the type 2s. You just start low, titrate slowly, and it has changed people's lives.
Yeah. All right, so the last one is, a little bit kind of further down the road, but not that far. So we're talking about gene therapy approaches in diabetes. And this is something that I've recently become, more knowledgeable in, because gene therapy to me was always something kind of over there, like this new technology I didn't really understand for these ultra rare diseases. But they've now been able to manufacture these products better so that we can use them in more common diseases like type 1 diabetes. So, type 1 is actually a common disease compared to some of these very rare forms of, genetic conditions. So what is a gene therapy? Well, essentially it's taking a virus, and a virus is very good, like a way that a virus replicates these colds that Steve and I have, is they get into the cells of your body and they use the machinery of the cells of your body to kind of replicate. So we can take advantage of that and take these viral particles. They're not infectious, but then we can put genes in them that we want the tissues to make. So in this case, there's a company called Kriya, Kriya, that has taken this gene therapy, put an insulin gene in the virus, and then you can inject into muscle tissue. So the virus gets into the muscle. The muscle is now able to secrete and make insulin as a way of treating and potentially curing diabetes. Get this, with a one-time procedure that is lifelong without immunosuppression. I mean, it's wild. They've done this already, cured mice, they've cured dogs, they've cured monkeys now, and actually looking to move into testing this in humans this year.
That's exciting. Well, there is precedent with other diseases, correct?
Yeah, absolutely.
Because you can grow anything you want, these little viruses. It reminds me of that movie Aliens with Sigourney Weaver. All of a sudden, pop out of your skin a pancreas. But to be serious, a one-time therapy, and these are islet cells that auto-regulate. They'll kind of like automatic insulin delivery, and it'll have glucagon when you need it too. These cells secrete glucagon when the blood sugars get low, I take it?
Well, it's putting just the insulin gene into like muscle tissue. So it's not islets. It's having like your muscle tissue be able to secrete insulin.
I see.
But pretty cool. And yeah, there's actually 5 approved gene therapies for other diseases in the US and I think worldwide. So this is not completely like novel. I mean, it is, but it's been done. Yeah.
That's really exciting.
Yeah. So, all right. So with that, let's get into the questions. Before that, we wanted to make sure to promote our One Conference, which is our only in-person event that we do. That's coming up in August. It's the weekend of August.
It's the first weekend, like 8th, 9th, 10th, something like that.
Is that right? Okay, I'm getting nods.
Yeah.
8th, 9th, 10th.
It's early.
So, and what this is, it's a Friday through Sunday in San Diego. We call it a conference, but it's more of a retreat, more of a camp for adults. There's talks that are given by mostly people living with type 1 themselves, endocrinologists. But like in the morning, there's a fun run and yoga, and Eric's Beatles cover band plays on Saturday night. And we have like 600-700 type 1s come from all over the country, take over this resort. Everybody gets a wristband based on like how long they've had type 1. Like if you're less than 5 years, you're a newbie and you get a red wristband or something like that. And 5 to 25 is something else. And Steve and I are legends. We've had it for over 25. So you can walk around this resort and see at the pool all these wristbands and just know that we're in the majority for once. And I don't know, it's awesome.
Yeah, we also have a exhibit hall there, not a huge one, but all the companies that deal with type 1 diabetes. But these lectures, I think it's way more than a retreat. It is a retreat. But we have some of the best speakers in the country, endocrinologists, diabetes specialists from other universities around the country come here to speak to their brethren, other folks with type 1. And they are cutting edge lectures. So we always learn a ton ourselves.
So we're telling you because it's the registration's open. So check it out on our website. Register now. All right. So some questions. It says, wondering about the immunosuppression, if that causes any other issues. So this is obviously with these islet cell transplants, getting immunosuppression. How would you handle that question?
Well, most of the time we think of immunosuppression shuts down our own immune system. You get infections easy. You might get, any type of cold easier. Any infection can be worse than it would be if you were not on immunosuppressants. But what happens is they use a lower dose than if you had a kidney transplant or a pancreas transplant. And they typically measure levels of the anti-rejection drugs that they use or drug. And they find a level that's good for you, and there's some precautions that you need to do, but it's not a major deal. And I've learned that being involved and talking to people in the Vertex study. But if you're a novice you think immunosuppressants, you start freaking out. So I think it's tolerable, and it comes down to the risk-benefit ratio. You as a potential person that would get it would be someone who would get knowledgeable, ask all the questions, and see if anything that else you have as part of your medical problems could add problems to what it would be with immunosuppressants.
Love it.
Some people are more at risk than others.
All right, I'm going to do a couple rapid fire.
Yeah.
So it says, I qualified for the infusion therapy, which I think they're talking about Tzield, but was rejected because my A1C was too good. Will this change soon? So, yes. So, right now, to delay type 1, it's approved for people that have these antibodies that are present and some mildly abnormal blood sugars. So, your A1C has to be between like 5.7 and 6.5. So, it's good news that your A1C is too low, but it's something you're going to want to monitor. And if it ever becomes even slightly elevated, then you would be an eligible candidate for this therapy.
I should say, though, that in the study where they used the data to approve Tzield, the average A1C was 5.2. So, the A1C is probably not the best, but like Jeremy said, just hang in there, repeat the test yourself, and then eventually you will become eligible.
Yeah. Is the name Vertex for infusion via the portal vein? Yes, Vertex is the company, Vertex. Any information on iPhones and Android phones for Omnipod users using Dexcom Omnipod tubeless insulin pump? Which is better, iPhone or Androids? Which streams without? Okay, so for the longest time with the Omnipod 5, it didn't work with the iPhone, and you had to carry around this other device, which was a real pain. And now it does work with the iPhone.
Yep.
People have said that it's generally worked better with Android. That's what it initially was working with, but supposedly it works well with both now.
I would just try the system, excuse me, that's best for you and see if it works out, because I think the CGM, sometimes they lose connectivity and things like that, but I think overall they work pretty well.
Yeah, this is a good question. Why don't CGM companies do more studies and get approval for sites other than the back of the arm? You can wear these things anywhere. This comes up all the time.
Yeah.
Any place you have a little bit of fat, which is pretty much everywhere in your body. I mean, Steve's a super fit guy, but you could put it you wear your pod on your back. I've worn my CGM on my leg, on my hip, on my stomach, on my arm. So it's just approved in these places because that's where it's studied, but you can wear it anywhere that works for you, that's comfortable, that doesn't fall off, etc. So experiment and don't feel like you're doing something wrong.
Yeah, any place on your body.
Yeah. Now, because it's approved there, the reps have to tell you that's where you have to wear it. But we can tell you the truth.
Yeah.
You can wear it anywhere.
And if you have a bad sensor, when you talk to someone on the phone to get a new one, you always wear it where it's approved. Otherwise, they may not send you another one.
Yeah. How can I get involved in gene therapy testing? We're not there yet. I would say go to the Kriya website, Kriya, and kind of stay tuned. This initially will be done probably outside the U.S. and then larger studies will come to the U.S. probably in the next 2 years.
Not at UCSD?
Not yet. Well, maybe. Yeah.
So there's more restrictions, kind of thing. In the States?
So it usually these things usually start outside the U.S., get some data, and then come to present them to the FDA.
Sign me up.
I will. Which CGMs will work with the twist? Do you know that?
For sure, the Dexcom.
Yeah.
And I believe they're working on the Libre as well, but I'm
Yeah.
not 100% sure. Go to their website. The company was founded by Dean Kamen, who's a bona fide genius, whose brother had type 1, and he's the one that developed the very first insulin pump and the Segway and the water purifier, the salt water purifier. He's very smart. He's got a huge army of engineers that have worked on this. So it's exciting. And like you said, like Jeremy said, pretty soon, all the different pumps, you'll be able to choose your pump, choose your sensor. There's also the implantable Eversense out there, and they're working on joining with a pump company as well.
Yeah. What is the dose of immunosuppressants? So this is back to islet cell transplant. It depends on the specific protocol. So that's something, if you're interested in in joining one of these studies, go to Vertex's website. If you are going to sign up, make sure to read through that carefully, talk it over with somebody that you might know involved with the study, or a friend of yours that knows these drugs. But it's generally lower doses than we use in kind of full organ transplant.
Yep, that's right.
Now, if you are on these immunosuppressants, do you have to avoid places, extra precautions, things like that? Generally not. I mean, you have to be kind of common sense about these things, because these are, lifelong drugs that generally people are on in low enough doses that you can be around people. You have to make sure that you're up to date with vaccines and all these kinds of things. But it's not like chemotherapy or something that you've just gotten and you're very vulnerable for infections.
And you can live a totally normal life. Just
Yeah.
don't come near us right now.
Yeah, exactly.
And you'll be fine. But you know what? It's always good to be cautious and to avoid places where you might come down with a very bad cold or a virus and things
Yeah.
like that. It's just common sense. The kind of things you do if you did not take immunosuppressants.
All right, so some kind of sophisticated questions here, which are good. Can you use your own stem cells to grow islets and then you don't need immunosuppressions? I mean, conceptually, yes, but to grow islets, you really need these like early stage embryonic stem cells. So there's nothing that you could harvest from yourself currently that would be able to kind of become islets. So currently they need to come from other sources. So we're not to the point yet where you could just draw somebody's blood, harvest some, of their own stem cells, create, beta cells and give them back to people. But that would be, kind of pie in the sky that if we were able to do that, then yes, you wouldn't need, immunosuppressive therapy.
Maybe someday.
All right, so I think that's it. Thank you all for joining us. We went through a lot in a relatively short amount of time, but the good news is we want to leave you with the impression that there's a lot going on in the type 1 space. All these fields are advancing, very quickly, from curative approaches to preventative approaches to people like us, that have had it for a long time to use technology or maybe islet cells. So I always say I hated giving these talks 3-4 years ago when there just wasn't much to talk about, and now we don't have enough time. It's so exciting. And the good news is we've done a lot more on each of these topics. Like a specific topic we'll do a podcast on or a video. So if you're hungry for more information, please go to our website or YouTube channel, all those things to check it out.
Yeah, and we have some excellent podcasts, more long form information.
Yeah. Well, thanks for doing this, Steve. Good seeing you, and hope you feel better. Hope I feel better.
Yeah.
And we'll see you guys on the next one, and hopefully we'll see you at the One Conference.